Then we had the advent of ultrasound, where we saw the incredible rise in brachytherapy, both LDR and HDR. And then we moved on to fiducial marker placement, and then therefore tracking the prostate through intrafractional treatment with stereoscopic x-rays. And then we had CT, where we had 3D anatomy, so we could actually see the bladder, rectum, and prostate and incorporate things like CBCT. Now we're seeing, here, at least in India, it seems like on the way to getting your morning chai, you're walking through an MRI and a PSMA PET CT, so it seems an audience that I don't need to discuss with the revolution in terms of imaging using MRI and PSMA PET. And we already know that MRI is very important in the diagnosis of prostate cancer. 2 landmark trials showing that pre-biopsy MRI leads to better diagnosis of significant and clinically insignificant prostate cancer to better guide treatment. And our surgeons here, I know most of the audience is surgeons, but we know MRI is used for surgical planning, both for the neurovascular bundle preservation, how to approach the median lobe, and also we heard yesterday, the width and length of membranous in the urethra that can be spared. MRI is not unique to surgery and biopsy. We've been using it for decades in radiation planning, but we know that fusion and registration to our CT base is not completely concordant and relies on us increasing the margins that we have to treat prostate cancer. So let's see if I can get this video working. So this is what our MR-Linac looks like on the left, and a CT-based, same patient. So you can see it's shades of gray on the right versus actual delineation of bladder, rectum, prostate, and you can see a rectal spacer clearly on the MRI. Again, this is a low-field MRI compared to CT. And so our workflow, we do offer rectal spacing in New York, but what we do allow is there's no fiducials or post-spacer MRI. So the patient gets a spacer, gets an MRI sim, and then moves on to treatment. The CT and simulation are done, but we've been able to, or will soon be able to, eliminate the CT based upon, as we heard, sort of using AI platforms in order to get synthetic CT. So here's the MRI, here's a deep learning synthetic CT, this is the ground truth CT, and the difference map between the two. Contour is done on the platform, planning and quality assurance on the same platform, and this is what I want to spend a little more time on, is that this is the first time with any kind of technology in radiation oncology that you can actually see what you're treating. Every surgeon here has shown videos, live videos of what they've been doing, but without an MR-Linac, a radiation oncologist cannot actually see what's happening. And so this is 8 frames per second with real-time and automated beam gating. Our margins are 2 millimeters, and we only allow 5% of the CTV outside. So within the next 3 minutes, we're going to go through all the data that we have so far, because the pictures are nice, but what is the data supporting any of the use of this? So Dr. Kishan at UCLA ran a pivotal randomized trial comparing CT-based treatment versus MR-based treatment. 178 patients were randomized. This was supposed to be a much larger trial, but the Data Safety Monitoring Board stopped it short because of the toxicity difference. And so the dose here is given a little bit spicier than what we see in India, and then on the PACE-B trial of 40 gray, the margins were different, 2 millimeters on MR and 4 millimeters on CT. Elective nodal treatment was allowed, 25 gray, which is familiar to this audience, along with boosting of the gross nodes and dominant intraprostatic nodules. Bottom line basically showed better acute GU and GI toxicity between the MRI and CT. That's not just a physician-reported outcome. They also saw it in patient-reported outcome in terms of clinically relevant IPSS. So the MR-Linac afforded margin reduction, but also allowed better contouring, better visualization, and real-time tumor targeting and tracking with this technology. So that's one trial. Last week, Jonathan Lehman and his colleagues at Brigham published a meta-analysis looking at the acute toxicity of MRI adaptive treatments. So on the Mirage trial, there was no adaptive treatment. These were just used as MRGRT. And what they showed in the meta-analysis is basically looking at really contemporary trials using CT, SBRT, mainly through CyberKnife platforms versus patients on MRI-guided SBRT, adaptive SBRT. And the key difference between GU toxicity and GI toxicity is the method of treatment, using MR or CT-based treatment across both profiles. So we've heard a lot about 2-fraction treatment. Credit to Dr. Tree, who's will be letting us know soon on a trial of 2-fraction treatment, randomized trial between 5 fractions and 2 fractions, 24 gray in the 2-fraction with a 27 gray integrated boost to the GTV. Along with that MR-Linac, there's a large registry study called Momentum, close to 4,000 patients, I think, at this point, led by, of course, prostate cancer. Not to be, outdone by Dr. Tree, we have a randomized trial similar, comparing 5 treatments to 2 treatments. Same stratification relatively same stratification factors. It's open at multiple centers, about 25% enrolled, and again, the primary outcome will be a non-inferiority design at a 2-year endpoint. Post-operative setting, this again run by the group at UCLA, looking at CT versus MRI. This was a non-randomized trial, but basically showing better profiles of MR-guided SBRT in the post-operative setting. This is the last trial we'll discuss briefly, is looking at we have an ongoing trial that is just completed called Shorter, looking at 5 fractions versus 20 fractions, same randomization, and what you can see here is basically we've been very strict on our CTV coverage and real-time tracking. This will be reported soon. Preliminary data here, interim analysis when the first 45 patients who were enrolled had 6-month follow-up, did not show non-inferiority between the 2 arms, and this will be presented at a conference not quite so near here, but soon. Last slide here, really next frontier, combining focal therapy with radiation. This is not a combination therapy of the drug kind, but this is something we are exploring, and it's leveraging both the expertise of urologists and radiation oncologists. Thank you.
Thank you so much, Dr. Himanshu Nagar, for finishing in time. I'd like to invite Dr. Amit Joshi, who is a professor in medical oncology at Tata Memorial Hospital, Mumbai. Sir, you've got 7 minutes.
So, till the time you have heard about the whatever going to the future, and now in medical oncology, the future is already here. So I will briefly talk about 3 entities which have 2 has already come into the practice, and 3rd will be soon. So CAR T-cell, just a few basic slides. The CAR is a acronym for a chimeric antigen receptor T-cell therapy, which involves the genetic modification of patient's autologous T-cell and to express a CAR-specific tumor antigen on those T-cells. So this is the diagram. So these are the steps. First, the T-cell from the patient's body is collected, and they are shifted to a manufacturing unit. And from that, the T-cell are being isolated. And the most important step for the T-cell is the introduction of a specific the chimeric receptor in the T-cell with the help of a viral vector. So this is the most important step in the whole, which is in the last panel. So this is the most important step where the T-cell is being introduced with a viral vector, particular receptor. And with this, there are certain expression of certain receptor on the T-cell. And then these T-cell are expanded in vitro, and then the expanded cell are then again sent to the hospital or place, and then it being reintroduced into the patient's body. Before that, a lymphodepletion, because as such, the T-cell might not be able to expand into the patient body, so some sort of what we call as a mini conditioning regime is being done to lymphodeplete the normal T-cell of the body, and then this T-CAR cell is introduced into the body. And so this is the structure of a modified CAR T-cell. So this is the transmembrane part, and this is the part of which is going to attach with the T-cell into the body, and this is the intracellular domain which will give the signal. So this diagram is showing how this T-cell is going to, modified T-cell is going to work into the patient's body. So this is the T-cell which is having a specific receptor, what we call as a CAR T-cell receptor, and with the help of this CAR T-cell and with a specific receptor, this T-cell will be T-cell will be activated, and it will release certain cytokine which will kill the tumor cells. So this is another modified diagram how this CAR T-cell functions into the body. So what happens that the transduction of T-cell with viral particle harboring the CAR encoding transgene leads to the stable expression of CAR on the surface of the transduced T-cell. So this is the transduced T-cell, And with the activation of this, so there are certain receptors which are already present into the tumor cells. With the help of this T cell get activated, and they started reducing, secreting certain enzyme, what we known as a perforin and granzyme, which then starts killing the tumor cell. So this CAR T cell has already, so there are at least 6 approved CAR T cell therapy which are being used in the practice, but mostly it is in the hematolymphoid malignancies. The first indication was the acute B-cell leukemia, and after that, at least there are, so very difficult to remember these names for us also, being a medical oncologist. So there are at least 7 approved indications. So from the acute leukemia to the DLBCL and now the multiple myeloma. So these are the FDA approved, and in our country, we, in Tata Hospital has run a trial for the ALL, and the one trial is going for DLBCL. So this is not the hypothetical. This has already come into the practice, and next few years we will have a routine, like we are giving immunotherapy, the CAR T cell, where the questions for the solid tumor, has this started? So there were some inherited problem like leukemia or the lymphoma, where you have a specific antigen against you can form a specific CAR T cell. But this problem is with the solid tumors, where the tumor-specific antigens targeting a tumor-specific antigen, and the microenvironment, how to reach the CAR T cell into the particular tumor cell, that is a challenge. But still, there are trials ongoing, and these are the 2 trials in the RCC. So this is the LO316 trial, where the anti-CD17 allogenic CAR T cell has been used, and the 17 patients has been treated. This is a phase 2 data. And if you see the result, the overall response rate is 33%, and some patients are after a follow-up of around 20 months, the disease is still controlled. So, and patients who are having a 3 median line of therapy, so patient has progressed over 3 line of therapies, then receive the anti-CD70 allogenic CAR T cell, and this is going to be the next future of a therapy in medical oncology. And in the RCC, there are another trial, the Cobalt RCC trial, which has shown the disease control rate in the range of around 77%. So these are the very early results, but the things, the development in which are moving in this direction, I am pretty sure that this cell therapy will be a reality, like we are giving the immunotherapy in current era. So the CAR T has just entered into the era of the solid tumor. So this was the result for RCC. Similarly, the prostate cancer area. So the PSMA targeting the TGF beta sensitive armored T cell. This is a phase 1 trial. But if you see the result, 5 of the 13 patients developed the CRS, which I will just explain later on. And 98% out of this 98% patient has a reduction in the PSA. So that means this is a phase 1 trial. So it has already shown that the CAR T cell therapy is feasible in patients of multiply treated prostate cancer. And the data which is coming is really encouraging, and definitely we are going to see more and more number of trial in this era. So the only thing from the perspective of the CAR T cell therapy, the cytokine release syndrome and neurological toxicity, these are the 2 major challenges. But with the availability of a specific anti-IL-6 therapy, this number has significantly reduced. And I think in next 2 or 3 years, we will have a phase 3 data for a CAR T cell in solid tumors. This is the therapy which has already been approved, the gene therapy in solid tumor, particularly the bladder tumor, which has been discussed, the BCG refractory tumor. This is a very recent last year approval of FDA for this, what we call as a nadofrigen fibrodinamic VNCG. It's a viral vector bond therapy for a patients who are having BCG refractory disease and they does not want to go for a. So this was very recently approved, and the mechanism of action for this is that this is an adenovirus vector. With the genetic engineering, the reproductive sequence of that adenoviral vector has been cleaved, and it has been inserted with the interferon alpha segment. Can I take 1 or 2 minutes more, because this is going to be, so this particular segment which is having an interferon on this, and with this modified viral vector is then introduced into the bladder cells. With this is the diagrammatic representation of this, with the modified adenovirus, which has lost its potential for replication, and the same segment has been replaced by a interferon producing segment. And when this cell being introduced into the urothelium, the cells start secreting, and with the help of this interferon, ultimately we all know that when this interferon, the normal cell starts secreting, the more and more number of T cell will infiltrate and will the tumor cell. So this is not the theoretical, this has been already approved, and this was a randomized trial which has shown that the benefit of, so these are the two patient cohort, one is the CIS cohort and a high-grade T1 cohort, and patient have been of this who or of a BCG refractory disease, intravasically this nadopharyngeal fibroadenivec VNCG, this is, and if you see the result, this is the high-grade recurrence-free survival, high-grade recurrence-free survival in a CIS cohort and T1 and TA-T1 cohort. If you see up to the 1 year patient of our CIS cohort, 50% of around approximately 50% patient still have not recurrence. These are the patients who are a BCG refractory, and these are 60%. So this drug has got FDA approval and it is being used in the. This is the last slide for a CRISPR CA19 and CAS9. So this is another going to be the next important development, what we call as gene editing. So this is a relatively difficult concept to understand, but in this, with the specific CRISPR and CS9, the desired segment of a gene, which is being responsible for whatever this is mostly used full in a disease where there a single gene is responsible. So this gene segment is cleaved, and this with the help of CRISPR Cas9 technology, and the desired segment is introduced with this. So what happens that this segment of a chromosome or the DNA where disease causing sequence is there, it is being cleaved, and a normal segment inserted. So the phase 2 and 3 trial for the sickle cell anemia and a transfusion dependent thalassemia, this has already shown positive data, and the FDA has also approved this CRISPR Ca9 technology in the management of a refractory sickle cell anemia and thalassemia, and this is just going to transform the management of a cancer cell in future. So these are the three technology: the CAR T cell, the adenoviral vector, and the CRISPR9 technology. And this CRISPR9 is the next blockbuster from the medical oncology perspective. We will identify. So the concept of a designer baby, the same is that you can want whatever gene you want to introduce, do this technology, remove the segment and introduce the segment of a DNA what you want.